Hi, my name is Sunil Badve. I'm a nephrologist at St. George Hospital and professor of medicine at University of New South Wales in Sydney, Australia. I would like to thank the organizers for giving me the opportunity to speak at this conference. Due to the travel restrictions, I was not able to travel to Belgium. I truly miss visiting this beautiful city, and I wish you a great conference ahead. These are my disclosures. I also have a conflict of interest that I should mention here, that I was the lead author of the CKD-FIX trial, which I will describe in my talk in detail. This is the outline of my presentation today. I will first describe the epidemiology of hyperuricemia in chronic kidney disease, then discuss association between hyperuricemia and various clinical outcomes in chronic kidney disease. I will also review clinical trials evaluating the effects of urate-lowering therapy in chronic kidney disease. Let's get started. In vertebrates, uric acid is formed through the breakdown of unwanted purine molecules. It is an intermediary product in most other mammals. Unlike the majority of mammals, uric acid is the end product of purine metabolism in humans due to the loss of uricase activity during the evolution of hominoids. It is primarily generated in the liver by the action of xanthine oxidase. Very little uric acid is normally ingested. Most circulating uric acid is freely filtered in the kidney, with roughly 90% of the filtered load normally reabsorbed along the nephron. Renal excretion of uric acid represents approximately 60 to 70% of total uric acid excretion from the body. A small proportion of uric acid is secreted in the intestine. Therefore, it is not surprising that decreased renal excretion of uric acid accounts for up to 90% of hyperuricemia cases. There is an inverse relation between serum urate levels and eGFR. Hyperuricemia is more prevalent in advanced stages of chronic kidney disease than earlier stages. For example, in this German study involving more than 5,000 patients with chronic kidney disease, 61% patients reported to have hyperuricemia. This proportion was 44% in CKD stages 1 and 2, but the proportion increased to 60% for CKD stage 3A and 70% for CKD stages 3B, 4, and 5. The prevalence of gout also increased with the worsening of kidney function, and 36% patients with chronic kidney disease stage or 5 reported to have gout. The relation between hyperuricemia and chronic kidney disease is also bidirectional. Chronic kidney disease is highly prevalent among individuals with hyperuricemia. In this US cohort study involving more than 5,700 individuals, the proportion of individuals with chronic kidney disease increased at higher levels of serum urate. In this figure, the blue bar represents CKD stage 3 or worse. CKD stage 3 or worse was present in only 8% of individuals with serum urate levels between 6 and 6.9 milligrams per deciliter. These proportions for CKD stage 3 or worse increased with the worsening of serum urate levels reaching to 53% among individuals with serum urate levels greater than 10 milligrams per deciliter. After reviewing the epidemiology or prevalence of hyperuricemia in chronic kidney disease, let's review the association between hyperuricemia and various clinical outcomes in chronic kidney disease. Sodium intake has been low for millions of years in our species history. According to one history, the anti-natriuretic and vascular effects of elevated uric acid contributed to blood pressure maintenance during a time when climatic changes forced early hominoids to better conserve sodium. At that time, uricase inactivation was thus advantageous. Additionally, there were other possible advantages of the loss of uricase in humans, such as its antioxidant actions that may have helped with greater longevity, intelligence, and neuroprotection. The most dramatic increases in sodium intake seen during the past century transformed this system of sodium conservation into an essentially maladaptive trait postulated to contribute to the modern epidemic of hypertension. Hyperuricemia is associated with several clinical consequences, the most important being gout. Several patients with hyperuricemia also have asymptomatic monosodium urate crystal deposition. Several cohort studies also show that hyperuricemia is associated with disorders such as hypertension, obesity, dyslipidemia, insulin resistance, endothelial dysfunction, and possibly cardiovascular events. These are systemic consequences. As far as renal consequences are concerned, hyperuricemia could lead to acute uric acid nephropathy, chronic uric acid nephropathy, uric acid nephrolithiasis, and uromodulin kidney disease, also known as familial juvenile nephropathy. Elevated serum urate levels are associated with increased risk of onset and progression of chronic kidney disease and kidney failure. Observational studies have shown a linear association between serum urate levels and various clinical outcomes, including albuminuria, onset of chronic kidney disease, progression to kidney failure, cardiovascular events, and death. Each 1 milligram per deciliter increase in serum uric acid level is associated with 22% increased risk of incidence of chronic kidney disease. Each 1 milligram per deciliter increase in serum uric acid is also associated with 8% increased risk of mortality in patients with chronic kidney disease. Another meta-analysis showed that compared to the lowest tertile of serum urate, the highest tertile was associated with 52% increased risk of mortality in chronic kidney disease. These observational studies are well supported by several preclinical studies, and I will briefly describe 3 experiments here. In the first experiment, rats fed the uricase inhibitor oxalic acid, became hyperuricemic, and developed elevated blood pressure, and their kidneys exhibited an ischemic injury, increased juxtaglomerular renin, and decreased macula densa nitric oxide synthase. In the second experiment, hyperuricemia was induced in 5/6 nephrectomized rats by feeding them oxalic acid. In these animals, blood pressures, proteinuria, and serum creatinine were significantly higher. In the third experiment, hyperuricemia was induced in rats by feeding high fructose diet. These animals had elevated blood pressure, plasma, triglyceride, and insulin levels, and decreased glomerular pressures, renal vasoconstriction, and decreased uh, afferent arteriolar area. Urate-lowering therapy with either Allopurinol or febuxostat prevented the development of these abnormalities. It must be kept in mind that association does not prove causation. Obviously, you cannot randomize someone to a high or normal serum urate level. To tackle this shortcoming, Mendelian randomization, a form of genetic randomization study, can be used to assess causality between an outcome and a given biological variable. This is done by studying the relationship between the outcome and the genetic determinant of the biological variable of interest. The idea behind Mendelian randomization is that alleles derived from both parents are randomly assigned to the gametes during meiosis. Therefore, the process is unaffected by confounding factors. The principal urate transporters in proximal tubule epithelial cells are shown in the figure on the left side of the slide. Urate reabsorption at the apical membrane is regulated by SLC22A12 mediated exchange of urate for intracellular organic anions and monocarboxylates. The other two transporters, ABCG2 and SLC17A1, mediate urate secretion in the apical membrane. SLC2A9 at the basolateral membrane is responsible for urate reabsorption into the circulation. SLC2A9 is also known as GLT9 or GLUT9 or glucose transporter 9. Several reports of subjects with homozygous inactivating GLUT9 mutations demonstrate that these subjects have no net reabsorption of urate, presenting with fractional excretion of uric acid of 100% or greater. This transporter SLC2A9 also has an opposing effect of transporting uric acid into the intestine. Genetic variation in a urate transporter such as SLC2A9 can therefore function as a proxy for variation in serum urate that is genetically independent of confounding influences on disease. Mendelian randomization studies showed conflicting results on causative role of uric acid and kidney outcomes. The Uric and Framingham heart studies showed that the activity of renal uric acid transporters in raising serum urate was actually beneficial on the renal function with better estimated glomerular filtration rate in these individuals. The FIN-DIAN study showed no causal relationship between uric acid and kidney outcomes in patients with type 1 diabetes, and another study showed that a polymorphism of the GLUT9 urate transporter gene was strongly associated with chronic kidney disease progression. In summary, epidemiological studies showed that asymptomatic hyperuricemia may be associated with the onset of progression of chronic kidney disease. Preclinical studies showed that uric acid may play a causative role, but Mendelian randomization studies showed conflicting results on causative role of uric acid on renal outcomes. And therefore, only randomized controlled trials can establish a cause and effect relation between uric acid and chronic kidney disease outcomes. In this part of my talk, I will review trials evaluating the effects of urate-lowering therapy in chronic kidney disease. I will briefly review the results of 3 published placebo-controlled randomized trials evaluating the effects of urate-lowering therapy on the progression of chronic kidney disease with at least 2 years of follow-up. The FEATHER trial enrolled 443 adult Japanese patients with chronic kidney disease stage 3 and asymptomatic hyperuricemia with serum urate levels between 7 to 10 milligrams per deciliter. The CKD-FIX trial enrolled 369 patients with stages 3 or 4 chronic kidney disease and increased risk of CKD progression. Increased CKD progression risk was defined as urinary albumin creatinine ratio greater than 265 milligrams per gram or decreased in eGFR greater than 3 ml per minute in the preceding 12 months. In the PERL trial, 530 patients with type 1 diabetes, serum urate greater than 4.5 milligrams per deciliter, eGFR between 40 to 100 ml per minute, and diabetic kidney disease were enrolled. We should note that all 3 trials excluded patients with a history of gout. In the FEATHER trial, patients were randomized to febuxostat or placebo. The starting dose of febuxostat was 10 milligrams once daily, which was gradually increased to 40 milligrams daily from week 8. The total study follow-up was 108 weeks. In the CKD-FIX trial, patients were randomized to allopurinol or placebo. The starting dose of allopurinol was 100 milligrams daily, which was increased to 200 milligrams daily after 1 week and 300 milligrams daily after 8 weeks if all pre-specified criteria for dose escalation were met. I will discuss these criteria in the next few slides. The total study follow-up was 104 weeks. In the PERL trial, patients were randomized to allopurinol or placebo. The dose of allopurinol varied according to eGFR. Total study follow-up was 3 years plus 2 months with a washout phase. This slide describes dose escalation criteria used in the CKD-FIX trial. For an increased dose adjustment of the study medication, all of these criteria must be present. And these are no new onset skin rash or reaction, hemoglobin has to be greater than 80 grams per liter, neutrophil count has to be more than 2.0, eosinophil count must be less than 0.60 or less than 20% of previous value. Platelet count must be more than 100. ALT must be less than 3 times the upper limit of normal. Serum creatinine should be within 20% of previous value. And most importantly, treating physician should feel comfortable increasing the dose based on clinical circumstances. This is the summary of dose escalation phase, which lasted for 12 weeks. At baseline, all patients started with 1 tablet daily for 4 weeks, that is the dose of 100 milligrams daily. If tolerated, the dose of allopurinol or study medication was increased to 2 tablets daily at week 4, 3 tablets daily at week 8, and after 12 weeks, patients continued 3 tablets daily or the maximum dose achieved at that study visit. The maximum allowed dose of allopurinol in this study was 300 milligrams daily. Now, what is the rationale behind using this allopurinol dosing strategy? Multiple studies have shown that strict adherence to the previously used handy dosage guidelines resulted in inadequate control of hyperuricemia. There is also a good evidence that higher than recommended doses of allopurinol was not associated with an increased risk of adverse events in patients with gout, including those with chronic kidney disease. Also, starting dose is a risk factor for allopurinol hypersensitivity syndrome. Dose adjustment on the basis of serum urate level was not permitted at any time in the CKD-FIX trial. This is mainly because no particular threshold of serum urate level has been identified for target from clinical studies. Dose adjustment also would have resulted in inadvertent unmasking of the randomized intervention, which we wanted to avoid. Furthermore, we instructed all participants to stop the study medication immediately and report to the study site if they developed a new skin rash, mainly for patient safety. This slide describes the study medication dosage at 12 weeks. In the allopurinol group at 12 weeks, 69% patients were taking 3 tablets daily, 9% patients were taking 2 tablets daily, and 5% patients were taking 1 tablet daily. Whereas in the placebo group, 70% patients were taking 3 tablets daily, 15% patients were taking 2 tablets daily, and 6% patients were taking 1 tablet daily. In the FEATHER trial, at baseline, the mean estimated GFR was 45 ml per minute. Median urinary albumin creatinine ratio was 120 milligrams per gram, and the mean urate level was 7.8 milligrams per deciliter. In the CKD-FIX trial, the mean baseline estimated GFR was 31.7 ml per minute. Median urinary albumin to creatinine ratio was 716 milligrams per gram, and the mean serum urate level was 8.2 milligrams per deciliter. In the PERL trial, the mean estimated GFR was 74.7 ml per minute, and the mean iohexol-based GFR was 68 ml per minute. The median urinary albumin excretion rate was 41.6 micrograms per minute, and the mean serum urate was 6.1 milligrams per deciliter. In the FEATHER trial, 30% of the participants had diabetes at baseline, whereas in the CKD-FIX trial, 58% patients had diabetes. In the PERL trial, by design, all trial participants had type 1 diabetes. In the FEATHER trial, at week 12, the mean serum urate level decreased by 46% from 7.8 milligrams per deciliter to 4.2 milligrams per deciliter. And the difference in the serum urate level between the febuxostat and placebo groups was sustained throughout the 108 weeks of follow-up. In the CKD-FIX trial, at week 12, the mean serum urate level in the allopurinol group decreased by 35%, from 8.2 milligrams per deciliter to 5.1 milligrams per deciliter and remained at 5.3 milligrams per deciliter up to 104 weeks of follow-up. The mean difference of 2.7 milligrams per deciliter was sustained throughout the follow-up between the allopurinol and placebo groups. In the PERL trial, at week 16, the mean serum urate level in the allopurinol group decreased by 35% from 6.1 milligrams per deciliter to 3.7 milligrams per deciliter and remained at 3.9 milligrams per deciliter for the duration of the intervention period of the follow-up and returned to near baseline value of 5.9 milligrams per deciliter after the 2-month washout period. The primary outcome measure of the FEATHER trial was eGFR slope. The results showed that there was no statistically significant difference in the mean estimated GFR slope or the end of the study estimated GFR values at 108 weeks between the two groups. However, this trial was limited by the inclusion of a low-risk cohort of patients who had almost no appreciable decline in estimated GFR over the study duration of 108 weeks, which resulted in inadequate statistical power to properly evaluate the effect of urate-lowering treatment on CKD progression. The primary outcome measure of the CKD-FIX trial was change in eGFR from baseline to 104 weeks. Change in eGFR or eGFR slope did not differ significantly between the allopurinol and placebo groups. Allopurinol also had no effect on clinical kidney outcomes, which was a composite of 40% decline in estimated GFR, kidney failure or death, or individual components of the kidney outcome. The primary outcome measure of the PERL trial was baseline adjusted iohexol-based GFR after the 2-month washout period. The results showed that there was no statistically significant difference in the primary outcome between the allopurinol and placebo groups. There was no statistically significant difference in the baseline adjusted iohexol-based GFR at the end of the intervention period between the two groups, as well as slope of GFR. In the FEATHER trial, there was a statistically significant difference in patients with gout flares between the febuxostat and placebo groups. In the CKD-FIX trial, there was no difference in patients with gout flares. Of note, the combined number of deaths in the CKD-FIX and PERL trials were greater with allopurinol than placebo. However, owing to the small number of events observed for this safety outcome, this finding should be treated as an exploratory result only and should not be considered either as definitive or a reason to deny urate-lowering treatment for patients with chronic kidney disease and gout. The reported adherence to urate-lowering therapy in clinical trials as well as clinical practice is very low. In the CKD-FIX trial, 30% patients in the allopurinol and 25% patients in the placebo group discontinued study medication. In the CARES trial, 56% patients in the allopurinol group and 57 patients in the febuxostat group discontinued study medication. Various cohort studies have shown that adherence to urate-lowering therapy among individuals with gout is as low as 22% and at best is less than 50%. Based on the results of these trials, urate-lowering treatment should not be prescribed for asymptomatic hyperuricemia. The FEATHER trial enrolled patients with CKD stage 3 only, and there were no specific kidney disease progression eligibility criteria such as proteinuria. 47% patients had proteinuria at baseline with a median albumin creatinine ratio of only 120 milligrams per gram. By using the proteinuria and or historical decline of estimated GFR, the CKD-FIX and PERL trials enrolled specifically those participants who had a high CKD progression risk. In the CKD-FIX trial, only 10% patients had albuminuria in the A1 KDIGO category, 19% in A2 category, and 71% in A3 category. In the PERL trial, 36% patients had urine albumin excretion rate less than 20 micrograms per minute. 38% had urine albumin excretion rate between 20 and 200, and 26% patients had urine albumin excretion rate greater than 200 micrograms per minute. While a single trial does not represent the broader CKD population, these trials collectively involved patients with eGFR values ranging between 15 to 100 ml per minute and proteinuria levels ranging from normal to severely increased, and KDIGO CKD risk categories varying from moderate to very high. While one can argue that these trials excluded individuals with a low KDIGO CKD risk category, this category is not an ideal trial population due to very low rates of kidney outcomes and no appreciable decline of estimated GFR over the life cycle of a clinical trial. Furthermore, due to the very low risk of kidney disease progression, these individuals do not require any specific therapeutic intervention to slow progression of kidney disease. A commonly asked question is the effect of urate-lowering therapy on eGFR decline modified by baseline serum urate level? The FEATHER and PEARL trials enrolled patients with serum urate greater than 7 and greater than 4.5 milligrams per deciliter respectively, whereas there was no serum urate based eligibility criteria in the CKD-FIX trial. Why did we not include a serum urate based eligibility criteria in the CKD-FIX trial? The answer is that observational studies show that even serum urate levels in the normal range and as low as 4 milligrams per deciliter were associated with increased risk of kidney failure, suggesting that normal uricemia may not be entirely harmless. Furthermore, the available data shows that there is a linear relationship between serum urate level and clinical outcomes, with no particular threshold of serum urate identified for trial enrollment or target to treat. In the FEATHER trial, febuxostat treatment resulted in an impressive 46% reduction in serum urate levels, whereas treatment with allopurinol resulted in reductions of 35% each in serum urate levels in the CKD-FIX and PERL trials. These reductions were not only large enough to test the hypothesis, but also sustained throughout the follow-up duration of all three trials. Subgroup analysis of all three trials shown on this slide showed that baseline serum urate level did not modify the effect of febuxostat or allopurinol on their respective primary outcomes. The results of these three trials do not support the view that hyperuricemia plays a causal role in the progression of chronic kidney disease. But before we entirely rule out a cause and effect relationship between uric acid and CKD progression, let us have a look at more recent data. SGLT2 inhibitors reduce serum urate levels. This begs a question: does serum urate mediate the effect of SGLT2 inhibitors on kidney outcomes? The CANVAS program showed that SGLT2 inhibitor dapagliflozin reduced the risk of CKD progression in patients with type 2 diabetes. Treatment with dapagliflozin reduced the serum urate levels modestly, with the average difference at the follow-up uh, between dapagliflozin and placebo of only 0.40 milligrams per deciliter. Despite this modest reduction, the mediation analysis of the CANVAS program showed that serum urate independently mediated the effect of dapagliflozin on the kidney outcome. Despite large and sustained reductions in serum urate levels in the FEATHER, CKD-FIX, and PERL trials, urate-lowering treatment did not slow the decline of eGFR. Then why would such a modest reduction in serum urate levels in the CANVAS program mediate the beneficial effect of dapagliflozin? This mediation analysis had several limitations, including its post hoc nature, the inclusion of only measured biomarkers, inability to assess mechanisms that were not assessed by any biomarkers, inability to control for interaction between mediators, and inability to provide robust estimates of uncertainty. Moreover, nephroprotective effects of SGLT2 inhibitors are likely to be exerted via multiple mechanistic pathways rather than lowering of serum urate. There has been a renewed interest in urate transporter 1 inhibitors. The CITRINE trial showed that among patients with type 2 diabetes and albuminuria, compared to placebo, the combination of Verinurad and febuxostat reduced serum urate levels by 60% at week 12 and 64% at week 24. Interestingly, this combination also reduced urinary albumin creatinine ratio by nearly 40% at week 12 and 50% at week 24. The SAPPHIRE trial is an ongoing phase 2b trial with a target sample size of 725. The study population includes adults with chronic kidney disease, eGFR greater than 25 ml per minute, urinary albumin creatinine ratio between 30 and 5000 milligrams per gram, and serum urate levels greater than 6 milligrams per deciliter. There are 5 randomized groups, and these groups will receive Verinurad with or without allopurinol or placebo. The primary endpoint is change in urine albumin creatinine ratio at 6 months. The secondary outcomes are change in urine albumin creatinine ratio and kidney function at 12 months. The clinicaltrials.gov record shows that this trial is now completed, so we should expect the results sometime this year. It is not clear whether Verinurad will be tested in a phase 3 trial at this stage. Now, how about combining urate transporter 1 inhibitor, a xanthine oxidase inhibitor, and an SGLT2 inhibitor? In this small trial involving 36 adults with asymptomatic hyperuricemia, the combination of Verinurad, febuxostat, and dapagliflozin resulted in greater reduction in serum urate levels than the combination of Verinurad and febuxostat. To the best of my knowledge, this combination is not being tested in any other existing or ongoing trial. To summarize, despite large and sustained reductions in serum urate levels, urate-lowering treatment did not slow the progression of kidney disease. The CKD-FIX trial showed that a large and sustained reduction in serum urate levels could be safely achieved with allopurinol in patients with moderately advanced chronic kidney disease with the use of a carefully measured dose escalation strategy. Prospective trials are required to evaluate the effect of SGLT2 inhibitors on gout flares in patients with or without chronic kidney disease. Prospective trials are required to evaluate the effect of urate-1 inhibitors on clinical outcomes. I thank you for your attention.